we want to show a new device, the multifunction occluder. So I will, can you quickly get on to the PowerPoint presentation, Ronak?
26-year-old male was diagnosed to have congenital heart disease at 2 years of age, was relatively asymptomatic in childhood. Now he has NOA, it's a class 2 hepatic intolerance. On examination, weight is 57.7 kg, pulse rate is 80 per minute, blood pressure is 130 by 80 millimeter of mercury, saturation 99%, apex in left 6 intercostal space in mid-clavicular line, S1, S2 normal, LV, S3 present, grade 5 by 6 pan-sterling murmur in the left lower sternal bladder. X-ray shows cytosolitis livocardia CTR of 60%, main pulmonary artery segment dilated and pulmonary plethora. ECG shows sinus breathing, ventricular rate of 75 per minute, QRS axis of 0 degree, PR interval 180 milliseconds, LV volume overload pattern. On echo there is LALB volume overload with moderate sized perimembranous VSD shunting left to right. On the left side of the screen there is apical 5-chamber view showing the perimembranous VSD shunting left to right. This is the parasternal long axis view. Now this is the size of the VSD is around 10 into 9 millimeters, shunting left to right with interventricular gradient of 106 millimeter of mercury.
Go to the LAO.
The final diagnosis is moderate size 10 into 9 millimeter perimembranous VSD, shunting left to right, dilated LALV, good biventricular function, NOAHA class 2. Now the plan is VSD device closure.
So Dr. Ramya, who is my colleague, I have with me Dr. Kamal from Iraq, who is also scrubbing with me, and Dr. Ramya will be the echocardiographer. She will echo live. We have a transesophageal echocardiography setup. In the short axis view, it was little closer to the anteroseptal tricuspid commissure. We can also say that there is a reasonable muscular margin that is surrounding the defect in some of the views. Here, if you see that it is edging on to the septal tricuspid leaflet scordae in the frozen frame.
Measures our VST to 9 millimeters, and this is explained of our VST. Here we can see the fixed frame of our VST, which is exposed in the 3D.
Show that 3D again. The marker is not matching, but you can see in the live picture that there is a previous live picture. There is a separation from the aortic valve. So the hemodynamics are live fluoro. The hemodynamics are normal pulmonary artery pressures. We did not do a QPQS because of significant LV dilatation. And our plan is to directly cross antegrade the VSD from the right ventricular catheter. So what we do is we have a internal mammary artery catheter that is positioned in the pulmonary artery with a pressure guidance. So we are slowly withdrawing the catheter. Now we have dropped into the right ventricle. So we are slowly bringing down the catheter till it starts facing the LV pressure. I don't feel that might happen, Damien. Anyhow, transesophageal echo is there. We will, if we get give him some sedation.
He's waking up.
So he's just give him some sedation. I'm slowly coming out now. We can take an AV loop as well, but I am, since the hole is little larger, I am planning to see whether I can get it directly across. Exactly, but my intention is to go through the venous catheter and deploy it through the vein. I'm reached the level of the VSD. Okay, we have slipped out. Just one attempt I will make again, or if it is not happening, then I will take a venous loop, AV circuit. I'm just getting my catheter across. Can you go to AP view? Go back to that same cranial. Yeah, now we are in the ascending aorta. So now I'm going to advance my internal mammary artery catheter all the way into the ascending aorta. Are you seeing live fluoro? Okay, so I'm advancing it into the descending aorta. So once it is in the descending aorta, I'm exchanging it to a stiff wire please, ampler superstiff. And I'll be exchanging that into a normal Mullin sheath 7 French. The size of the VSD measured 9 to 9.5 millimeter in the largest dimension, and I was thinking about a 14-12 multifunction occluder. What is your thought process? Or you want 12-10? The 14-12 will have a 18 millimeter disc. One difference between a multifunction occluder is it's not a self-centering device. It has got a tiny waist. I will show the device shortly. So I'm exchanging this into a 7 French Mullin sheath. Almost 9.5 millimeter, and our previous echocardiogram we got almost around 10 millimeter. So we can anticipate around 9.5 to 10, and the separation between the device and the aortic valve leaflets is almost close to 7 millimeter. So we are secure on the aortic valve. Yes, please. Yeah. Okay, so Ramya, can you show live echocardiography tricuspid valve? Yeah, get the color. Not much of color flow into the right atrium, Dr. Bharat. So right now, yeah, 12-10. I would take the floor opinion about what to do. I'll show the device in the meantime. So that there are, if there are some audience who have not seen this occluder, get it focused here, camera, close up. So MFO has got screws on both the sides. It is the distal end of the MFO is like an ADO. But the only thing is it is very short in its length, and then it has got a retention skirt on the right side. And if you carefully observe, there is a fabric, a single layer fabric in the middle belly. This fabric is there in the larger 3 sizes, that is 10-8, 12-10 and 14-12, whereas the smaller devices like 6-4, 7-5 and 8-6 do not have a fabric. it is compatible through a 6 French sheath. You can see that this is a 6 French loader, and now we are going to take this device, flush it. I am right now loaded a 1412, but I can change over to a 1210 right now. What Damian and whoever has used a multifunction occluder, what is your view? Yeah, one of the advantages, since it is a non-self-centering device, it doesn't hurt the AV node much, and so the chances of AV nodal injury is much remote in this particular product. So you can see that it is going in. As I told you earlier, it is compatible with a 6 French system. However, for the okay, my hand need not be shown. Fluoroscopy live. Yeah, fluoroscopy. Sorry, we didn't watch it. So this is going to be the device. This is the right, the left ventricular end of the device. Now, in order to get a landmark about where is the aortic valve, I am going to keep the pigtail here, so that I will notice when I am coming below the pigtail. I will also have a pressure guidance from the aorta when I am falling into the right ventricle, left ventricle and the right ventricle. So I will flush the side arm of the sheath now. Through the aortic valve, because this is a very soft device, Damian, I feel that it will possibly not cause a major problem for the aortic valve. In fact, there is a lot of literature, even about, lot of operators experience even about a regular ADO1 device that is brought through the aortic valve to form the aortic retention skirt like a ball and try to get it down. So I feel it is reasonably safer on the aortic valve. And see, right now I am coming down, I have got a pressure monitor. So now we are touching the pigtail now. I will just withdraw the pigtail. Yeah, I don't know how to exactly time it in the systolic opening of the aortic valve. I try it, but then I think it has to fall on its own. It fell now. Fluorostore. Yeah. So right now I will go on cine. Now, Ramya, you see the echo also. So now we have positioned the device. So echo big, yeah. Color now. So we can appreciate some sort of a tricuspid regurgitation right now, but I have my rigid cable across. And now let us see one LVOT long axis view for aortic valve. Yeah, is that Kevin Walsh? No, I want. Zoom there.
Yeah.
No, without that. Make mag. Zoom. Go up. Mag. Further mag. Yeah. Now you see. Actually, freeze it, Ramya, and show. You can see that in the closure point, the leaflets are marginally away from the disc. You see that gap? Yeah, the cusp. Okay. AR. You want to downsize it? Yeah, I can. No, I'm not like not keen on iotogram. Maybe I can do an LV angiogram. There is no AR at all. So iotogram is not going to be of great use. Okay, I'll do that. I'll do that now. Angiogram, two angiograms, one for iotogram and then one for LV angiogram. Okay, table up. Mag on the aortic valve. Aortic valve, double, zoom it. Ready for 25 at 15. 1200 psi. Yeah. So we are setting up first an aortic root angiogram, and then I will set up an left ventricular angiogram. Ravi inside. Ravi inside. Echo live. Ask him to go echo. Color. Yeah, there is no significant echocardiographic shunt. So go live on angio. So that is the angiogram. Freeze it. Freeze. Okay. Just go back. Make the valve open out. Yeah. Keep on going. Yeah. No. Go next frame. I think this is. I think there is a small gap there. Mag one more mag on this. Yeah, just move the frame. Go back. Okay. Wire. I'm actually very happy about this position. I feel that it is pretty secure. It is not going to hurt the aortic valve. I'm happy. But I heard, at a very close view, we are observing that there is a little bit of separation between the cusp of the right coronary and the edge of the device. I'll make one LV angiogram at same 25 at 15. DMAG. Yeah. Ready for angiogram? Ready? Yeah. Shoot. So the angiogram looks good, and show this angio again. Show the tricuspid valve now. Show the aortic valve now. Echo big. Okay. Now tricuspid valve. Yeah. Yeah, yeah, sure. Tricuspid regurgitation and come out. Tricuspid valve, okay. It's taken out. Thank you. Is it Dietmar?